Good morning. I'm Dr. Tanveer Janjua. I'm a board-certified facial plastic surgeon. Today I will demonstrate excision of a basal cell carcinoma in the left upper lip. One of my patients came in with a suspicious lesion. I biopsied it and it showed basal cell carcinoma, and now we are going to do a complete excision. And I will demonstrate it to you. Patient had a lesion right around this area that was biopsied. At this point you can only see the biopsy site, which can be very deceptive because it leads you to believe that the tumor might have disappeared, but it has not. So we have to do a complete excision and submit it for a frozen section or permanent histopathological examination to ensure complete removal. The most critical step in any of these surgeries on the face is the drawing, where you mark your planned excision. I usually start first marking the boundaries of the lesion to give me an idea, and then I go around with my planned excision areas. You have to try to use any natural curve or line. Had it been a little closer to the nasolabial groove, then the vertical axis would have been placed along the nasolabial groove. Since it is more medial, I'm trying to achieve the line of excision in a diagonal direction along the vertical wrinkles of the upper lip. Majority of these can be done with a nice elliptical excision, and that will be our plan for today. This surgery can be achieved with just plain local anesthesia, and I will perform an infraorbital nerve block followed by local infiltration prior to proceeding with surgery. The local infiltration has been done including a left infraorbital nerve block. We will start with our excision, and we will mark our specimen with sutures to orient for the pathologist. After the specimen has been removed, we achieve hemostasis, and as you can see, there's no bleeding whatsoever, which is great. To facilitate the closure and take the tension off the wound, we have to do some undermining. The undermining should be done laterally in this case and not medially, because we do not wish to pull the lip laterally. We rather pull the cheek tissues closer, and that will be achieved by lateral undermining. Mrs. B, you might feel a little hissing and buzzing noise. It should not hurt. If you feel even the slightest pain, please speak up. Lily, may I have you switch to the bipolar now, please?
Yes.
and we'll go up to 5. Thank you. We'll go back to the regular bovies. Setting of 5, please. As you can see, at this point we have done enough undermining that it allows us to pull the lateral skin over without any difficulty. The wound closure is initiated from the inferior aspect to ensure proper symmetry for the upper lip. I am using a 5/0 vicryl in the deep dermis for this purpose. As you can see, the lip does not get pulled in any abnormal fashion when this initial stitch is placed. If you cannot take a vertical bite of the dermis, it is okay to use a horizontal bite to approximate the edges. Before the second bite, it's always good to hold the stitch vertical to the wound edge and figure out where to take the bite. That would give the best shape to the lip. As you can see, at this point the edges have been approximated with a dermal stitch that ensures that there is no pressure or wound tension which can pull the skin apart, and the role of the skin suture with 6-O-proline is minimized. The only role it has is to ensure leveling of the skin edges so the end result looks a nice fine line. At this point the surgery has been completed, and if you notice, the lip maintains its contour. There is no upward pull or lateral pull. Also the alar groove is maintained. The rounding of the alar groove and the sill is very critical, and that has been maintained. And this will have minimal effect on the facial aesthetics. There is no distortion of vital structures of the nose or the lip. The stitches will come out in about 5 days, and eventually the scar will blend into the natural wrinkles.